Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide in another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists.
Wait, I forgot my
Create
sheet.
a free account and check us out today.
That's all right. Hello, everyone, and welcome to PerfWeb Corona 30, Part 2, Day 1. We'll have 5 days of it again this week, and then next week another 5 days. But let me just dive right in. We have limited time. We have 1 hour to get through a whole bunch of stuff. So first, thank our sponsors. Go visit them, okay? Visit them right now. That's number one. Second, social media. Like, follow, share us on Facebook, the Twitter, and LinkedIn. And also subscribe to our YouTube channel. We need 2.5 million more subscribers before the end of this program today. So you got to get it done for me. Subscribe, 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 and also give us the thumbs up. Thank you very much. Check out our websites if you'd like to join our faculty or you have a topic. I've actually gotten some emails, some really good topics. But if you'd like to join our faculty, you're a content expert, you have a passion for something, you'd like to teach, you have a really interesting case, just go ahead, send us an email. Let's get you on the program. Call us right there. contact@perfusioneducation.com. We have a call-in number. When you see this, you can call in. Call in, be live on the air, let your voice be heard. Would love the interaction. Call. So anyone who calls today will win a special prize. Anyone, a special prize. I'm not going to tell you what it is, but it's a special prize. It's a really special prize. Slido. We've got a program coming up. Go to either that QR code or go to slido.com, hashtag perfwebc30-8, and vote. The question is, are you scavenging anesthesia gases from the outlet of your oxygenator while on bypass? We'd like to know. Patrick needs it for his talk tomorrow. We've already got quite a few votes, but go on and vote so that we know what you think. All right? I want to introduce our faculty for today, including myself. Of course, I'm Joe Basha, your host of what is the largest, most comprehensive, best perfusion education resource that's out there, bar none. So not that I'm biased or not that I think special, but we're special, but I do think we're pretty special. I want to introduce John Ingram. Y'all know him. He's been on this program so much. John, can't thank you enough for being back here again today. You are really helping to pull this Corona 30 series over the finish line, and I think everybody really knows you by now. Anybody that doesn't, go to perfusioneducation.com, take a look at our faculty page. They can read your bio, learn about you, but all I can tell you is you have been an incredible resource for us, and we appreciate you so very much. So John Ingram, welcome to the show.
Well, hey, Joe, can you hear me okay?
We can hear you great. We see you're at work
All right.
again.
Yeah, well, you've got an incredible platform here, and I just enjoy being on it. I really do. So I put together, I think, a kind of a fun little slide presentation today, and then you're going to follow up with a little bit more current. But I'm hoping to have a little bit of fun with, if you can, blood transfusions and all the things that surround it.
Sounds great. All righty. Uh-oh, what happened? Oh, yeah, I have the clicker. Oh, I got to do your slides. Okay, I have the clicker.
Okay.
I thought something bad had happened. Listen, John, I got to tell you this. I just have to tell the audience this, okay? Sometimes we have technical difficulties, all right? Saturday, we stood in line for an hour and a half because the line to get in the store that we needed to go to was all the way around the building. I don't know how many deep it was. Got in there and bought, so we had to use this box. It was about this big. It was all integrated with all the software. But our technical guy, Magic, he added this new memory card to it, or several memory cards, a new graphics card, all this stuff that generates huge amounts of heat. And so when the producer, David, would be doing graphic stuff, it would get so hot that the CPU would shut off to protect itself. So we had portable air conditioners, central air conditioner, portable air conditioners, fans, everything blowing on it you could imagine, still to no avail, because the last program you and I did together Friday cut off. So Magic took that thing apart, because he's the computer science guy. He took that machine apart piece by piece, board by board, and put it all into this big giant box that has 12 fans in it. And so today's a test, see if it's going to work. So when they jumped over there, because I didn't have the clicker, I figured something bad had happened yet again, but it hasn't. So we're all good. I'm sure this talk is going to be a lot of fun. So go ahead, John.
Well, you watch the big TV stations, and they're all sitting at home, and even with their $1 million systems, they have plenty of problems, Joe. So I think you're doing a heck of a job. So
thank you.
So today, we're going to talk about blood transfusion. I'm going to do a little bit of a review. I'm try not to do the same old, good and bad of blood transfusion. In fact, I'm going to focus mostly on the negative. We all know we need to give blood when we need to give blood for hypoxemia and patients get unstable, but there's so many things that have come out about it. And then I'm going to try to give you each step along the way some fun facts. So we're going to start off with immediate transfusion reactions. And Joe, as you know, they go line by line. It's going to start off with just a very little bit about each one of these: acute hemolytic reactions, then acute non-hemolytic, allergic reactions, and then something you guys have all heard of, transfusion-related acute lung injury, TRALI, and then the favorite other one too, transfusion-associated circulatory overload, TACO. Then I'm going to talk about delayed transfusion reactions. Those I just listed were immediate. You see them almost right away, but the delayed ones happen days, sometimes weeks later. One of them, post-transfusion purpura. And then just going to basically focus on that one today, because it's kind of a nice one to talk about. And then I'm going to talk about massive transfusion reactions, people that require a lot of volume of transfusions, a lot of units. And one I'm going to talk about briefly is citrate toxicity. Then we're going to talk about, I think the next one is hyperkalemia, Joe.
Sorry.
I think that's
Sorry.
it. Yep,
Sorry
hyperkalemia. And then, of course, you're all familiar with coagulopathies that happen. And in between every one of these, I'm going to throw in some fun little known fun facts. Hopefully it'll make it a little bit more interesting than your normal blood transfusion talk. And at the end, I've got a whole little small snippet about gaps in our knowledge about blood transfusion. And these are all fun facts as well. So if you guys want to get started. Okay, so the transfusion dilemma, weighing known, this is the article, weighing the known and newly proposed risks of blood transfusions. This is the article that I referenced, the main article that is quoted throughout this entire talk. But in this review article about blood transfusion is 107 references. And I went ahead and left all the references in there. And you're going to see them in the quotes. And so in the introduction here, we'll just get started with, in the United States, red blood cell transfusions are given about 3 to 4 million patients a year. Acute transfusion reactions have been estimated to occur in about 20% of transfusions, about 1 in 5. And with serious reactions, only about 0.5% of the time. Now, the most important roles of transfusion, of course, are life-saving applications where you have severely bleeding patients and life-threatening or anemias, and people getting unstable as well. So basically, your critical level patients are going to get blood, right? But despite advanced and improved resuscitation strategies, when a patient needs blood, the patient needs blood. Transfusion remains virtually the only effective therapy in such patients, meaning there's really no substitute when you have to have it. And so here's a direct quote from that key paper I referenced in the beginning. Although red blood cell transfusion remains a key therapy prescribed by physicians of all specialties, there's actually little evidence base for the current practices. There's no clear indications for transfusion in most clinical settings. So we're going to take a closer look at all this. Also, red blood cell transfusions, the red blood cells, right, they're mainly administered to improve tissue oxygenation. There's no real specific laboratory parameters that consistently indicate the need for red blood cell transfusion. Physicians most often depend on their clinical expertise, and they look at the hemoglobin concentration to give them an idea if they should give blood. Now, the platelets are prescribed for bleeding, mostly after major trauma or during any major surgery or bleeding situation. FFP then is mostly transfused to replace coagulation factors, right? In acute bleeding situations, trauma, liver failure with bleeding, liver transplant, and by the way, to reverse vitamin K antagonist anticoagulation reversals, such as warfarin. If you don't have the time to wait for the warfarin to wear off and a patient has to go to surgery right away, FFP is your go-to thing. It's also used in thrombocytopenia and DIC. And then cryoprecipitate, of course, is used when we need fibrinogen and in cases of liver failure and massive bleeding. All right, so one last thing in introduction. Quote from the paper here, while transfusion is often considered a safe therapy with minimal side effects, in reality, a blood transfusion should be considered as a temporary organ transplant. You should keep that in mind. Many publications over the decades suggest the need for transfusion should be carefully evaluated, used only when possible, and considered as a last resort when patients are unstable and there's a life-saving measure. So, incidence of transfusion reaction. Okay, let's look at the incidence. A precise estimation of transfusion reactions is actually not feasible due to several issues. First, many reactions are wrongly attributed to the patient's underlying conditions and never actually reported. Secondly, you got the clicker there, Joe?
Oh, shit. Sorry.
Secondly, 50% of all transfusions are given in the operating room to anesthetized patients where reactions are more difficult to recognize. Thirdly, many transfusion reactions are not reported, and due to the lack of a rigorous transfusion reaction reporting system in most medical centers. Fourth, of the two types of transfusion reactions, the acute and delayed, the delayed type is often overlooked and commonly not reported. Delayed reactions include multi-organ failure, thrombosis, occurrence of tumors, and post-operative infection, and these are commonly overlooked, as I stated. So let's look at acute hemolytic reactions. Acute hemolytic transfusion reaction, AHTR, is typically caused by immune-mediated destruction of the ABO-incompatible transfused red blood cells. This is the one everybody thinks about where the wrong blood type is given to the wrong patient. The exact incidence of unintentional ABO-incompatible transfusions is actually unknown, but it's estimated to occur in somewhere in 1 in 38,000 to as high as 1 in 70,000 red blood cell transfusions. Now, for decades, acute hemolytic reactions were the leading cause of transfusion-related mortality, but that has now been replaced in the last couple decades recently, really, by the recognition of TRALI, transfusion-related lung injury, acute lung injury, which we're going to talk about. So now let's look at fun facts about acute hemolytic reactions. The severity of this acute hemolytic reaction is extremely variable and usually depends on the rate and total volume of the administered ABO-incompatible blood. However, 47% of the recipients of an ABO-incompatible blood show no effects even after receiving a full unit. And 41% only 41% show even any symptoms of getting the wrong blood type. The mortality, however, of overall blood transfusion mortality is 2% of all the different reactions. So let's talk about febrile non-hemolytic reaction. It's defined as a temperature increase of greater than 1 degree following transfusion in the absence of any other cause for a fever. The reaction may occur up to 1 to 2 hours following the transfusion, and reactions with chills or rigors with no fever actually are also classified as febrile non-hemolytic reaction. They're also the most common transfusion reaction that we have. The incidence varies actually. It varies with someone's age. It varies if they've had a prior transfusion, the type of transfusion, and some underlying illnesses they may have. So now let's look at a fun fact with febrile non-hemolytic reactions. They're more likely to occur in transfusion of platelets rather than red blood cells. In fact, many studies have been done, and they found somewhere between, different studies say different things, pretty wide range, but somewhere between 1 and 38% of platelet transfusions give this type of reaction, and only 0.01 to 6% of red blood cell transfusion give this type of reaction. So literally more than a 10 to 50 times incidence when you give platelets. Interesting. Women with a history of multiple pregnancies are a much higher risk for this type of reaction. So let's look at allergic reactions. Allergic reactions are common. Severity levels include a mild anaphylactic and even an anaphylaxis type reaction. The severe anaphylactic reactions, though, are much less frequent and are estimated at 1 to 20,000 to somewhere between 1 and 50,000 of all transfusions. These type of reactions occur in about 1 to 3% of transfusions of plasma-rich components, the platelets and FFP. That compared to only a 0.1 to 0.3% for red blood cell transfusions. So again, about a 10-fold increase in the reactions when you give patients FFP or platelets. So now let's talk about TRALI, transfusion-related acute lung injury. It's a serious transfusion adverse reaction characterized by acute onset of pulmonary edema with severe alveoli capillary leakage. So that's the important thing when you have TRALI. It's a sudden onset of pulmonary edema, and the alveoli capillaries have leakage going on. It's a very bad thing to be faced with. So the typical presentation of TRALI is the sudden development of dyspnea, hypoxemia, hypotension, and fever that develop within about 30 minutes to as long as 6 hours after the transfusion. So now let's look at a fun fact with TRALI. Again, it's more commonly associated with plasma-containing products, the FFP and platelets, which account for between 50 to 63% of TRALI fatalities. It's the leading cause, according to the FDA, of reported deaths related to transfusion in the United States. It's a leading transfusion-related incidence of death. Now, clinically, it's often impossible to distinguish TRALI from other acute respiratory distress. For instance, TRALI is clinically indistinguishable from ARDS. So now let's talk about transfusion-associated circulatory overload, TACO, right? It's basically congestive heart failure appearing immediately after a transfusion. And basically, it's exactly what it sounds like. And this is a fancy way of saying it's blood circulatory overload. So it's defined as a clinically adverse expansion of the intravascular volume that occurs when blood components are given and they exceed the cardiovascular ability to handle that additional volume and that additional workload. So this may occur as a result of some degree of pre-existing cardiac failure. That makes sense. And it cannot accommodate the additional volume, or it can be due to too rapid of an infusion of a large volume of fluids, mainly including blood in this case. So let's look at a fun fact with TRALI. Believe it or not, patients that are greatest at risk are infants. Makes a bit of a sense because you have to be very sensitive with their volume. But believe it or not, people above the age of 60 have a higher risk of this happening to them. The other ones kind of make sense. Patients with compromised myocardial function, patients that have renal failure or congestive heart failure patients. Those are basically usually unable to handle large fluid or already fluid overloaded. And TACO is estimated to occur in only about 0.1 to 1% of blood transfusions. Let's take a look at a delayed transfusion reaction. Post-transfusion purpura. Maybe some of you have heard of this, maybe you haven't. Post-transfusion purpura is a rare transfusion reaction, and it results in a sudden severe thrombocytopenia. Now this develops on average 9 days, ranging from 1 to 14 days. The average is 9 days of onset after a blood component transfusion has been given. A fun fact about this: serious disorders are only seen in multiparous women or in patients who have undergone previous blood transfusions. And because of that, the female to male ratio in affected patients is 5 to 1. This reaction is most often implicated in transfusions of red blood cells compared to the platelets and plasma, as we talked about in the other ones. Now this has become even more rare since we've introduced leukoreduction of the red cells, because it tends to remove the instigating antigens. Now let's talk about another delayed transfusion reaction, something called iron overload. This one I find very interesting. It's a common and serious complication of chronic red blood cell transfusion. Now this is often seen in patients with some type of hemoglobinopathy like thalassemia, sickle cell. You can also have it in myelodysplastic syndromes, aplastic anemia, hemolytic anemia, refractory sideroblastic anemias. And so what you're seeing here is that each red blood cell unit has approximately 250 milligrams of iron, but the FDA daily intake for iron in your diet is only supposed to be 18 milligrams per day. So you can see 1 unit of blood, how much iron is there. So these people who have to come back either once a month or twice a month, whatever it is, depending on their condition, those people of conditions I just listed there, these people have to come back because of their persistent anemias. This chronic transfusion can lead to a gradual iron accumulation in the tissues, and this causes morbidity and mortality. So that's a fun fact about this. Iron metabolism is altered in transfusion-induced iron overload. Once transferrin, that's your iron-binding protein in your blood, once that's saturated, the excess iron circulates as free iron and is then taken up by your organs like the liver, heart, lung, and endocrine organs. Iron accumulation in these tissues over time is what leads to end organ damage. Early cirrhosis has been seen in children as young as 7 years of age with thalassemia. Cardiac hypertrophy and dilatation is also common and is a leading cause of death among transfusion-dependent patients. Now let's look at massive transfusions. The transfusion of large volumes of stored blood products may lead to a number of complications. So we're talking about, if somebody's bleeding massively and you're having to transfuse somebody massively, of course you can have a dilutional coagulopathy with the volume overload and the loss of the blood. You can have a circulatory overload, TACO, that we talked about. These are all in massive transfusions. You can have something called citrate-induced hypocalcemia. You've heard of that probably. Hyperkalemia can develop. Massive transfusion is arbitrarily defined as transfusion of more than 10 units of red blood cells or replacement of one's blood volume in a 24-hour period, or a 50% blood volume lost within 3 hours. So let's talk about each one of those. So let's look at citrate toxicity. Sodium citrate is the anticoagulant of choice used in blood collection. In massive transfusion, excessive amount of citrate can produce a transient hypocalcemia and hypomagnesemia, actually, that may affect the cardiac rate and function. What's a fun fact about this? It's usually seen only in patients with liver failure and or severe hypothermia where the citrate metabolism is slowed. So two things are happening. Your liver metabolizes some of that citrate in addition to some of it binding the calcium. Treatment with calcium and rarely magnesium is tailored to the clinical findings and the ion levels. Now, in trauma, there's a general rule among trauma surgeons that 1 gram of calcium is given per every 4 units. That's just sort of a rule of thumb. You wouldn't really have to be that aggressive, but that's kind of a rule of thumb in trauma. And some of you may see this in your practice, even in cardiac. So let's talk about hyperkalemia. Storage of red blood cells causes the intracellular potassium to leak out of the supernatant. This is progressive and thus more significant in the older blood stored units. Older units have increased hemolysis also, which really releases potassium because, as you know, potassium is an intracellular ion. The total potassium dose in transfused red blood cells is only about 0.5 milliequivalents in shorter storage red cells, handful of days, but as high as 5 to 7 in units that are close to their expiration. So what's a fun fact about hyperkalemia? The irradiation of the red blood cell units that we're all sort of fond of, this actually accelerates the potassium leakage into the plasma of the stored unit. So let's look at gaps in our knowledge, just some fun facts in general about blood transfusions. In the last 35 years of research, has demonstrated that patients transfused according to current standards of practice experience striking increases in morbidity and mortality when compared with non-transfused patients, or patients even receiving fewer transfusions. Now, you probably all have heard that, but interestingly, patients that are undergoing cardiac surgery have significantly reduced mortality and multi-organ failure when randomized to receive only leuko-reduced transfusions. So the leuko-reduced transfusions have shown to be beneficial. But even those leukotransfusions are still associated with increased morbidity. So transfusions are associated with substantial increases in venous and arterial thromboses, raising the question whether transfusions alter recipient platelet and endothelial cell function. Patients with acute coronary syndrome, patients that have acute coronary syndrome, maybe they didn't need blood, maybe they did, maybe they were given blood because they felt it would help them. But if you give a patient experiencing acute coronary syndrome, they experience a dose-dependent increase in MI and mortality if they are transfused with red cells, according to observational studies. Okay, that's all I have, Joe. And,
wow, that was actually fun.
It was interesting.
That was great. That was fantastic. I do have a couple of questions, though, if I could, before I do mine. Can I go back to John's slides? I'm sorry. And I want to go to, I don't remember, let me get to the slide.
There's the outline there. You can go back a couple slides and see the outline and see if it refreshes you as to where you...
Yeah, I'll find it.
Okay. I didn't know what the time constraint was, so I hope I didn't go a little too fast.
No, not at all. It was pretty fast, but it was great.
Yeah, I tried to make it powerful as much as possible.
Here it is, right here. Okay. No, that's not it. That's it, right there. Many publications suggest that the need for transfusion should be carefully evaluated, avoided when possible, and considered only as a last resort life-saving measure.
Well, that's why I put it in quotes. That statement's a little aggressive, a little over-aggressive. And this article, just so people know, this particular review article, it came down on the negative of blood transfusion whenever possible.
Sure.
And I used it because it was so comprehensive. It covered even way more than the things I covered in my talk, and it used an enormous amount of references. But it was a anti-blood donation slanted article that you should keep in mind. And it's not used only as a last resort life-saving measure. It's used when patients are unstable and just need and are hypoxemic. And I kind of inserted that when I was talking through this sentence, but I probably should have added it, but it's a quote from the paper, so I couldn't change it.
No, I don't think you should have either. But I do think that it's worth us discussing it. And I'm done. I'm good with this slide, though. Thank you. I I think that that's an issue with this whole thing, is that there's these two camps. There's all blood transfusions are bad, and this other camp of let's just give blood, 1 unit. If you're going to give one, you may as well give two, and neither will the two meet. Right. So I do think that we have to be judicious with the use of blood and use it appropriately. But I don't know if you've seen the articles, but newer blood, fresher blood, if you will, blood that has not been stored for 42 days but only stored for 5 days, has much higher viability, much better. You don't have depletion of your 2,3-DPG, the potassium levels, and hemolysis is, of course, much lower. You don't have the elevated potassiums and so forth. And I'm concerned that the storage of blood being up to 42 days is just frankly too long.
It's an awful long time.
Yeah, it is. It's a very long time, but that is the limit. That's the allowable limit. I used to practice. I don't know if you've done this yourself, but if I called for blood and I got it and it was going to expire tomorrow, I would tell them send it back and get me a unit that is within the past 7 days. And the lab used to get really upset with me, but the blood bank. But I got it. I wasn't going to give that blood, but because I do think you have to recognize it is also about DO2. If you don't have enough oxygen carrying capacity in your blood, then the patient is going to have a higher heart rate. You're going to have to you may have an tissue oxygen deficit. There are real consequences to having anemia, and each patient is going to be a little bit different, especially on cardiopulmonary bypass, but in the postoperative phase where you just got through operating on a heart that started off with a 20% ejection fraction because of acute coronary syndrome and a failed PTCA, and now you're in the operating room. And they, you come out of there with a hemoglobin of 6 or 7, they don't do well. So they, what do? Do you manage the patient today to get through to tomorrow? Or do we worry about what might happen in 5 or 10 years? I know it's a different animal than massive transfusions and, for other disease states. I'm really sort of bringing it into the cardiovascular perfusion realm, if you will. What's your view on transfusions? How do you feel?
Well, having I'm not a pediatric perfusionist, but we do have peds here at this hospital, and I run by them occasionally. But having our pediatric perfusion counterpart colleagues adopted this as standard of care. Don't they only give blood that's less than 5 days old or 7 days old? They have a cutoff. They will only give very, very recently donated blood. Mm-hmm. They don't tolerate units past. Somebody can call in who's a pediatric perfusionist. I think it's 5 days or 7 days.
Yeah, it's very
beyond
short.
That. They won't entertain giving it at all.
You're absolutely right. And then of course they also take their blood and wash it. They use the cell saver, the auto transfusion system. They wash their red cells before they give it to the patient. I wonder if we shouldn't all do that.
There's enormous benefit to that. I was reading about that, not only in this article here, which I used, but other articles affiliated. Washing the red blood cells, most people, I think, probably don't want to be bothered with it and think maybe it's not terribly necessary. But if you look at the studies, there's some definite benefits to washing bank blood before you give it to the patient.
Mm-hmm. Absolutely. And then one of your fun facts, if I can, do you know what the number one cause of death is associated with blood transfusions?
No.
Clerical error.
Yeah, that has been talked about in so many blood transfusion talks that I saw that and I elected not to put it in, but it actually, there's 3 levels to it. One is the phlebotomist who drew the blood from the patient made a mislabel on the lab tube. Mm-hmm. It's not only two people looking at a blood unit and looking at it and still somehow giving it to the patient. Those days probably are very rare now, but you have 3 levels. The phlebotomist who draws it mislabels the tube, something happens in the blood bank, and then something happens in the OR. Mm-hmm. And between all 3 of those, when you think about it, somewhere along the line, it might happen every now and then.
Absolutely. I think it's very unlikely to check a unit of blood now at the bedside or the ICU or in the operating room and give the wrong unit. I think it's very difficult to do, but it can still happen. It can still happen.
We had two patients with the identical name, and only a one or two numbers different on their medical record number.
Yeah, and I think that's alerted now.
We had two patients with the identical name on ECMO.
Yeah, that's amazing. Amazing how that can happen. And that's, and I think now they have systems where if you have that in a hospital, there's some alert on both of their names that there's another patient with the same name or close match or something like that. I've seen that at least a couple of times. Okay, well, I'll go ahead and do mine and get it out of the way. My talk today is also going to be a little bit on the fun side. It's about blood transfusions. So what got me started down this track is this letter from the, it's basically three different agencies, AABB, American Blood Centers, and the American Red Cross. So it's a joint letter, and it was sent to the Commissioner of the Food and Drug Administration, Stephen M. Hahn, MD. And you can read this, later at your leisure, but I'll just go ahead and sort of, did I get to it? Yeah. Did I have it on there? Yeah. Okay. But I'll just do some summarizing if I can. So the letter says that basically they want to maintain a safe and adequate blood supply, and it's critical to the health objective. Need for blood is still there. Reduced need because of halting of elective cases, so that kind of helped out a little bit. Trauma, cancer, emergency procedures still are going to exist, though I imagine trauma went down a little bit since everybody was staying home, these stay-at-home orders. Less people shooting each other. COVID patients on ECMO will certainly have a need. Now, that wasn't in the letter. That's my own editorialization. You have patients on ECMO long term, there's a good chance they're going to need a blood transfusion at some point in time. Donations have been adversely impacted. For example, schools, churches, community centers all closed, so they're blood drives, really. And as of March 16th, the blood industry, and this was their word, industry, and I put it in quotes as well, has seen 4,000 canceled blood drives that equal essentially 130,000 fewer donations. So the potential for more blood drive cancellations was concerning the Joint Task Force on this. Fewer healthy donors because people were having, COVID and there was a problem with them getting there because they're sick. Absenteeism of staff, the people that actually run them, their ability to draw the blood was going to be a problem. Blood will continue to be needed even as the outbreak grows, they pointed out. It's a life-saving thing. Reagents for type and cross-match and antibody status were going to be in short supply. And they really need to get the message to blood donations, that blood donations are not social gatherings, and for the government to do more with messaging. So the three from the task force, the AABB, the American Blood Banks, American Red Cross, all said to the commissioner of the FDA, you all need to message to let people know that this is not a social gathering. We need blood. Very important. So before I get started on the history of blood banking, I just want to point out some things. Trauma continues to be the predominant cause of death for individuals up to the age of 44 years old. There were a reported 1.2 million deaths due to road accidents, traffic accidents in 2018 globally. And even though traumatic brain injury is the leading cause of death from trauma, exsanguination continues to play a significant role. Among patients who arrive at the emergency department for trauma, hemorrhage is the leading cause of death within the first hour. Within the first 24 hours of arrival to the emergency department, nearly 50% of deaths are a result of hemorrhage. Trauma patients also require large amounts of hospital resources and are responsible for using approximately 70% of all blood transfused at a trauma center. Now, you look at cardiac surgery and blood transfusions, we use about 20 to 25% of the nation's blood supply just for cardiac surgery. So cardiac surgery and trauma consume a lot of blood. Transfusions also place a high burden on the cost of treatment. One study found, this was from England, that in the traumatic patient, nearly 12% of their total financial cost was due to transfusions. Thank God they have socialized medicine. Transfusion protocols from donated cross-matched blood remain the standard of treatment for the hemorrhagic patient, although it is not without risk and potential adverse side effects. Transfusion of donated blood carries the risk of, you just described many of them, disease transmission, citrate toxicity, hyperkalemia, hypothermia, hypomagnesemia, acidosis, sepsis, respiratory failure, and thrombotic complications. That's a mouthful. For these reasons, autotransfusion has widely been known as an alternative or adjunct to cross-matched transfusion therapy with fewer risks. Autotransfusion has not always been a safe procedure, however. The first known documented procedure of autotransfusion was performed in 1818 by Dr. James Blundell. I'm going to show you a picture of him and something about his work. Dr. Blundell became frustrated by the loss of a patient due to uterine hemorrhage. Blood transfusions have been attempted for many years before Dr. Blundell, but he was the first to successfully attempt it from experimentation with canine specimens. Later, he would try his procedure on humans, but not without risk. The estimated mortality rate from his procedure was a whopping 75%. Thanks to modern advancement of, obviously, infiltration and sterile techniques, and of course, cell salvage machines, autotransfusion is widely accepted as a relatively safe procedure. So I wanted to lay that foundation if I could. But this whole thing started 2500 BC. And here's a tomb from Egypt on bloodletting, or there's not an image, but it's just a statement of that. But though bloodletting was often recommended by physicians, it was carried out by barbers, eventually symbolized by the red and white striped barber pole that we're used to seeing today. 1897, of course, Bram Stoker has published Dracula, taking from blood from other living beings to sustain life of the undead. And by the 1800s, it was being seriously questioned, bloodletting, as a good therapy, although some people still did believe in it, okay? And some of it persisted even into the 20th century. In 1492 is the first historical transfusion attempt. Now, this is great. This is classic. So they needed to save Pope Innocent VIII. So they took 3 10-year-old boys, they took their blood and infused it into the Pope's mouth as he sank into a coma. The Pope and the boys all died. So that's the first historical transfusion attempt. In 1667, the first recorded human transfusion was documented, taking human blood transfusions administered in France. King Louis IV's doctor transfused blood of a sheep. So here is essentially a xenotransfusion into a 15-year-old boy who survived. In 1818, the first human-to-human transfusion was done, and this was Dr. Blundell, who I just described, and there's a picture of Dr. Blundell on the right side. So it was 12 to 14 ounces of blood. The patient did die, though, after initially showing improvement. Of course, there was no ABO typing yet. We didn't know about antibodies. There was a lot of factors involved. Who knows why the patient actually died, but certainly it makes you question what happened there. It wasn't until 1901 that the three main blood groups were discovered. It wasn't until 1902 that the fourth blood group, AB, was identified. And it was 1907 when cross-matching was finally utilized. In 1914 was the first non-direct transfusion. And what do I mean by that? Prior to this, it was taken directly from the patient into the recipient. This was put in a receptacle of some sort, anticoagulated with sodium citrate, and then given later. So that's why they call it a non-direct transfusion. And in 1917, I'm sure everybody saw the movie 1917, the Battle of Cambrai in World War I, the first blood depot was established to prepare for that battle with O blood with the citrate glucose solution, because they knew there was going to be massive casualties and massive blood loss at this Battle of Cambrai. In 1922, blood donor service established in London. In 1930 was the first network of blood facilities. And in 1935, the first in-hospital blood facilities came into being at the Mayo Clinic, of course, in Rochester, Minnesota. 1936, Barcelona Blood Transfusion Service, and that was for the Spanish Civil War. 1937, the term blood bank came to be. In 1939 to 40, there was a discovery of the RH blood group. So prior to that, you didn't know if it was negative or positive. So from 1900, 1901, or 1901 and 1902, for the ABO, AB type, it wasn't until 1939, 1940 they discovered about it, the RH factor positive or negative. 1940, U.S. sends blood plasma to Great Britain. This was again during the war, Second World War. 1941, Red Cross organizes blood plasma war effort. 43, transfusion-transmitted hepatitis is first described. 1947, American Association of Blood Banks is founded. 1948, development of the plastic bag. Prior to that, it was bottles. 1962, America's blood centers are founded. 64, community blood center established. 71, the CBC moves to current location in Dayton, Ohio. 1965, cryoprecipitate is developed. 71, the FDA finally starts to regulate this stuff. And in 1971, it is finally tested for hepatitis B. 1981, the first case of AIDS transmission through a blood transfusion. 1982, the blood-borne pathogen theory is established. 1983, the AIDS virus is isolated. 84, virus is identified. And in 85, the first AIDS blood screening test is done to make sure that the blood you're getting is not contaminated with HIV. 1999, they started doing nucleic acid amplification testing, or NAT testing, making it more thing. But at the end of the day, no conversation about blood banking can go finished without talking about Charles Drew. Charles Drew, as you can see here, he was an American physician and physiologist. He helped to develop the storage and transportation of fresh frozen plasma, which would be needed for the war effort. He was the first director of the American Red Cross Blood Bank, not the American Red Cross Blood Bank, very important, in 1941. But he resigned from his posts after informed that the military ruled that blood of African Americans would only be accepted, but would have to be separated or segregated from that of whites. And Charles Drew happened to be African American. So that's pretty damning as far as I'm concerned. That's a real crummy fun fact, but one I think that should be said. There was a story that is mythical, but it's a story that he was in a car accident because he died very young. I think he was 45 years old when he died. He was a very young man. in 1950, that he supposedly died by being refused blood transfusions somewhere in Mississippi after an automobile accident, but that is not a true story. So this is a very important slide, and why it's important is it shows two things. It shows that blood availability, I can't get my mouse to work. There you go. There you go. The green are transfused units. The red are distributed units or supply. Now you can see here the amount distributed and the amount used were super tight in 2013. A little bit better here, but basically this range is very, very narrow. And now that's one thing it shows you. The other thing it shows you is that as need increases, blood drives, advertising, all the things that marketing that happens usually follows, and you're able to get the blood that you need. But the blood banks were certainly concerned with COVID and how that was going to affect their ability to provide services. Now, blood is an industry, and I called it an industry, they called it an industry. This is very important. 3 nonprofit organizations dominate the $2 billion American market for whole blood. The industry leader is the Red Cross. It has 53 regional blood centers that collect more than half of the nation's blood supply, or 6.5 million units a year. The Red Cross's Blood Services Division last year had $741 million in revenues and $14 million in tax-exempt profits, meaning excesses of revenues over expenses. Total revenues raised for its relief services were additionally about $945 million last year. This is in 16. So the product that they get, and John, you pointed this out to me last night, the product that they get is a donation. Now, there are costs. You got to have the bag, you got to have the people, you have to have the infrastructure, you have to have the van, you have to do all the testing, you have to have the refrigerators for the storage. There certainly are costs associated with obtaining the blood, but the product itself is a donation. It costs them nothing. You pointed that out to me last night. They still are under a lot of pressure. They rely on donations. They have to assure the safety. Testing, 42 days for RBCs, but only 5 days for platelets. So these products keep having to be replenished. You don't get a product from a patient and you know you're going to use it. In fact, I didn't put it in here because the talk would go too long, but there's a lot of blood gets thrown away. Preservation and distribution, of course, are a big thing. So we can go into a discussion, but there's my talk.
Very interesting, Joe.
Some neat stuff.
Very neat stuff. Most of that I had not heard.
Good. You heard something new. But yeah, we talked last night, and you had some passion. In fact, you got me spun up because of your passion about the about blood banking. Do you want to discuss it since we're here?
If you want me to, I will. Yeah, it's controversial.
I'm sure, but I love controversy. That's what controversy sells.
I have said this to a number of people, and I have found probably 50-50, at least 50% of the people that agreed with this point of view and 50% who perhaps did not. But the thing that I've always found unusual and I guess interesting is that the blood banking industry is the only industry that I've ever heard of whose core raw product is given to them for free. Now, quickly people run out and say, yeah, but what of all the buses and the people working and the processing and the screening and the expiration of the thing? Yeah, the best thing that I could compare this to is the oil industry. Their raw product needs enormous refinement. It needs enormous expense to put wells in, tens of hundreds of millions of dollars. Then they have to pump it from the ground, and it's in no condition to be used. It's raw crude. The refinement that goes on is huge expense, probably 70-80% of the cost is refining this crude that comes from the ground so it can be auto fuel and jet fuel and all the different lubricants. It's an incredible process, incredibly expensive, but they don't get it for free. I don't know any industry that gets a product for free. Now here's the thing. If you had not just showed me how incredibly profitable this industry is, I might have some sympathy for that. They are enormously profitable. And if you look at the fact that, yes, they have a lot of costs, but what they get paid for their product is enormously profitable. They can have a certain percentage of their product go to waste. They can have these $1 million buses to go all over the country, all over the place, doing outside blood drives and all the things that are involved. I'm sure it's an enormous operation, the screening and everything. But the profit that they make from a unit of blood is enormous. It's up there with the pharmaceutical industry and the oil industry companies. And you just demonstrated that. So, my only beef is that when they're constantly on the TV saying there's a blood shortage and begging people to come in and donate 2 hours of their time to donate blood, which, by the way, that's no small needle they stick in your arm for 2 hours. And they send you away with 2 crackers and a small 3 ounces of orange juice on your merry way. To me, if they were to look into something that would incentivize, people to donate blood in a better way, they would probably never have a shortage. That's my opinion.
Yeah, that's really good. So I remember years ago, and it is a lot of years ago, the drill sergeant came in and said that he needed volunteers. And if you were going to volunteer, you had to go over there, form a line. And if you didn't want to volunteer, you could stay behind and have a barracks party. And I was not really too dumb of a kid. And I was like, a party. Okay, there's nothing about this place thus far that would make me believe they're going to have a party. So I went over to the volunteer line. I didn't know what it was going to be, but I knew it couldn't be as bad as what was going to happen. And they herded us on a bus and took us to the hospital, and all of us donated blood, which was well. Listen, you can knock it, but I'm going to tell you what. At that point in time, I don't know if that nurse was pretty or not. She looked beautiful to me at the time, or whoever she was, sticking that needle in me. But for the orange juice and the cookie that came after it, getting to look at her for a short period of time, it was well worth the size needle they stuck in my arm. In fact, I could have had 2. When we got back, the folks that stayed for the barracks party were still working, and the barracks party involved taking cleanser, a bucket of water, and a toothbrush, and scrubbing all of the cracks between the boards of the flooring and the walls. And they were going to be there for a long, long time. They didn't get done. That whole night they didn't get done. They worked all the way until the next day. I'm not sure the relevance of that, but I thought I'd tell the story.
That's great. I can tell you a story when I was in college, and this might have been when it first came out. You remember when plasma donation came out? There was no such thing as plasma donation, but what you would do is go to the blood bank. Yeah. You would donate a unit of blood, sit there for a while they went back, spun it down, separated it out, reinfused you back your red blood cells. Then you donated another unit and did the same thing again. It was a good 2.5 hours while you waited, and they paid you $40. That was the new thing. Well, let me tell you something. I was in college. None of my friends donated blood. I never thought about it. We were too busy. We all went down to the plasma center and donated and got our $40. So, when I brought this up that people should be compensated something for donated blood, that they would probably have enormous. Blood bank people have said to me, we tried that and we got nothing but homeless people coming and donating blood. Well, when we saw that at college, there was lines out the door, and you could tell the homeless people from the college students. And you know what? You have to screen your people better. That's my point. But I can tell you that if you pay people $50 to donate blood or plasma, I'm pretty sure, and if you would never have a shortage. You might have to add some personnel and do some things to screen people better, but you wouldn't have a shortage of product ever again. Well, and they claim they've tried that, and that's simply not the case. But
yeah, that's a really good point, because even today you can sell plasma. You can't sell whole blood, but you can sell plasma, which doesn't make any sense to me whatsoever, frankly. But it is what it is. I'd love to do a program one day, and I'm going to look it up and spend the time to research it. But I wonder what the systems are, the regulations and systems are in different countries. Because I know that I've done some work down in Mexico, and if you need blood, if you're a patient in Mexico and need blood, people or people that you can recruit have to go donate for you. There's just not blood available. That if you need it, it's just at the blood bank. So it's a totally different system, and it just seems really wacky, but it is what it is, and that's just their system. I'd be curious to know what the system is around the world, because the ones that sell it, what is their risk of disease transmission? Is it higher? Is it not higher? Do they do the same testing? I really don't know, but I do know that the blood bank system is enormously profitable. That, I think your point is well stated and obvious. But you can sell plasma, but you can't sell platelets, and you can't sell whole blood. I don't think it makes any sense. Or sell red blood cells and get your plasma back.
What do you mean sell it to who?
They have plasma centers where you can sell your plasma today.
Oh, they pay you to this day to come and donate plasma.
Yes.
Why,
it's not donating.
why is that any different than the other?
I don't know. That's what I was asking. That's my point. Is you're essentially selling your plasma. You can donate your plasma for pay, which is selling it, but you can't do that with whole blood. It makes no sense.
Yeah. Well.
Yeah, I agree with you.
They've for 100 years, they've convinced the American public that it's the right thing to do, that you're being a genuine humanitarian, you're saving somebody's life. And if you knew how much money they made off of you donating that 1 unit of blood, because they break it into 4 fractions. Right. Sometimes they break it into more than that. Yep. And each one of those fractions are hundreds of dollars.
Well, platelets are yes, raw cost to the hospital. Probably about $300 for packed cells, $500 for platelets. FFP, I think is lower, maybe $160 to $200. Yeah, you're probably making about $1,000. Cryo, you're probably making $1,000 to $1,500 a unit.
I'm not an expert, but I'm going to be pretty sure I've read $1,200 to $1,500 is the profit. Or the charge anyway, not the profit.
The charge.
For every time you've donated 1 unit of blood,
right,
the blood bank goes out and sells that to hospitals or whoever their clients are for somewhere between $1,200 and $1,500.
Right. Yeah, that makes sense. And then the hospital's going to upcharge it because now they have administrative costs. They have to go through all of the clerical aspects of it. They have to do. They probably have to do some kind of antibody testing on it. Then they have to, do a cross match with the patient. They have to get it to the place it needs to be infused. Then you have the infusion set. Then you have the nurses infusing it. Then you have the checks. Then you have more paperwork. And before you know it, the patient's paid $1,000. Well, you saw what I showed you from England. 12% of a trauma patient's total hospital charge, 12% comes from just transfusions. That's a lot. That's a lot for trauma when you have multiple operations, surgeries, broken bones, implants, all the things that you need with trauma. That's a remarkably high number that 12% comes from just transfusions. Miko asked a question though, and I don't know that I'm really capable of answering it. He says he wants to know about protocols of blood transfusions on CPB, especially in neonates. I can answer the question on adults. Sky's the limit. Everybody has a different way of looking at it. So it can be as low as 6 as a transfusion trigger to as high as 21 or 24 as a transfusion trigger. And I think it can be very patient dependent. But in neonates, I know they use blood, they prime with blood, they use a lot of blood. It's a small amount because it's a little teeny baby, neonate, but they use blood on those patients. But other than that, I can't answer it. I don't do those kind of cases.
I wouldn't venture to answer. Not being a pediatric perfusionist, I wouldn't want to wrong. Because
I'll try to ask the folks down at Texas Children's, Miko, and see what I can get. And then what I'll do is, if you can send me an email to perfusioneducation.com, you can see it down there in that corner over there. Send me an email to that email address. I think it's contact at perfusioneducation.com, and I'll try to get that answer to you from the experts down at Texas Children's. All right, so with that said, John, you have anything else?
No, I thought your information was great.
I think yours was too. It was fun. Actually, this was a really enjoyable show.
It's a lot of blood transfusion lectures, and I'm usually fall asleep, but these were fun.
Yeah, this was fun. And our system didn't break down, so that's a plus. And we're finishing on time, and I was told earlier that you and I cannot do a program within 1 hour, that there's no way, we're doing it.
I thought we were supposed to do 2 hours yesterday on Friday. I thought it was supposed to be 2 hours.
No, it's on the schedule. The schedule is published. No, today is from 5 to 6.
Oh, okay. Great.
Yeah, it's from 5 to 6. Yeah. It doesn't start my time and end your time, since you're on the East Coast. Oh, I'm getting told to cut. All right. We'll see you all tomorrow. What's going on tomorrow, Tuesday? I'm doing a talk tomorrow for Victoria Crumpton. Victoria can't be here or can't come on Skype. So I'm going to be giving a talk on less invasive cardiac output monitoring tools and the basics of hemodynamic monitoring in the critical care unit. Very useful for perfusionists, but also ECMO specialists and critical care nurses if they have such an interest. So we'll see. And then, John, I think you come back to us on Wednesday, don't you? No, that's Patrick. Thursday. Yes, pH and alpha stat blood gas management. So you're scheduled Thursday from 6 to 7.
Perfect.
So we're looking forward to seeing you then. Once again, thank you for being here with us, John. You're such a huge contributor. Can't thank you enough. And everybody there at home that's been watching or watches later this afternoon, thank you all for being here as well and using us as your resource for perfusion education. We appreciate you. See you tomorrow.
Thanks, Joe. See you on Wednesday.
See you, bud.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.